Page 95. Part 2, Cardinal Manifestations and Presentation of Diseases. Section 1. Pain. Chapter 19. Chest discomfort. Chest discomfort is among the most common reasons for which patients present for medical attention at either an emergency department, ED, or an outpatient clinic. The evaluation of non-traumatic chest discomfort is inherently challenging owing to the broad variety of possible causes, a minority of which are life-threatening conditions that should not be missed. It is helpful to frame the initial diagnostic assessment and triage of patients with acute chest discomfort around three categories: 1. Myocardial ischemia, 2. Other cardiopulmonary causes, pericardial disease, aortic emergencies, and pulmonary conditions, and 3. Non-cardiopulmonary causes. Although rapid identification of high-risk conditions is a priority of the initial assessment, strategies that incorporate routine liberal use of testing carry the potential for adverse effects of unnecessary investigations. Epidemiology and natural history. Chest discomfort is the third most common reason for visits to the emergency department in the United States, resulting in 6 to 7 million emergency visits each year. More than 60% of patients with this presentation are hospitalized for further testing, and the rest undergo additional investigation in the emergency department. Fewer than 25% of evaluated patients are eventually diagnosed with acute coronary syndrome, ACS, with rates of 5 to 15% in most series of unselected populations. In the remainder, the most common diagnoses are gastrointestinal causes, Figure 19.1, and fewer than 10% are other life-threatening cardiopulmonary conditions. In a large proportion of patients with transient acute chest discomfort, acute coronary syndrome or another acute cardiopulmonary cause is excluded, but the cause is not determined. Therefore, the resources and time devoted to the evaluation of chest discomfort in the absence of a severe cause are substantial. Nevertheless, a disconcerting 2 to 6% of patients with chest discomfort of presumed non-ischemic etiology who are discharged from the emergency department are later deemed to have had a missed myocardial infarction, MI. Patients with a misdiagnosis of MI have a 30-day risk of death that is double that of their counterparts who are hospitalized. The natural histories of acute coronary syndrome, acute pericardial diseases, pulmonary embolism, and aortic emergencies are discussed in Chaps 288, 294 and 295, 300, and 301, respectively. In a study of more than 350,000 patients with unspecified presumed non-cardiopulmonary chest discomfort, the mortality rate 1 year after discharge was less than 2% and did not differ significantly from age-adjusted mortality in the general population. The estimated rate of major cardiovascular events through 30 days in patients with acute chest pain who had been stratified as low risk was 2.5% in a large population-based study that excluded patients with ST segment elevation or definite non-cardiac chest pain. Causes of chest discomfort. The major etiologies of chest discomfort are discussed in this section and summarized in Table 19.1. Additional elements of the history, physical examination, and diagnostic testing that aid in distinguishing these causes are discussed in a later section. See Approach to the patient. Myocardial ischemia, injury. Myocardial ischemia causing chest discomfort, termed angina pectoris, is a primary clinical concern in patients presenting with chest symptoms. Myocardial ischemia is precipitated by an imbalance between myocardial oxygen requirements and myocardial oxygen supply, resulting in insufficient delivery of oxygen to meet the heart's metabolic demands. Myocardial oxygen consumption may be elevated by increases in heart rate, ventricular wall stress, and myocardial contractility, whereas myocardial oxygen supply is determined by coronary blood flow and coronary arterial oxygen content. When myocardial ischemia is sufficiently severe and prolonged in duration, as little as 20 minutes, irreversible cellular injury occurs, resulting in myocardial infarction. Ischemic heart disease is most commonly caused by atheromatous plaque that obstructs one or more of the epicardial coronary arteries. Stable ischemic heart disease, chap. 293, usually results from the gradual atherosclerotic narrowing of the coronary arteries. Stable angina is characterized by ischemic episodes that are typically precipitated by a superimposed increase in oxygen demand during physical exertion and relieved upon resting. Ischemic heart disease becomes unstable most commonly when rupture or erosion of one or more atherosclerotic lesions triggers coronary thrombosis, chap. 291E. Unstable ischemic heart disease is classified clinically by the presence or absence of detectable myocardial injury and the presence or absence of ST segment elevation on the patient's electrocardiogram, ECG. When acute coronary atherothrombosis occurs, the intracoronary thrombus may be partially obstructive, generally leading to myocardial ischemia in the absence of ST segment elevation. Marked by ischemic symptoms at rest, with minimal activity, or in an accelerating pattern. Unstable ischemic heart disease is classified as unstable angina when there is no detectable myocardial injury and as non-ST elevation myocardial infarction, NSTEMI, when there is evidence of myocardial necrosis, chap. 294. When the coronary thrombus is acutely and completely occlusive, transmural myocardial ischemia usually ensues, with ST segment elevation on the ECG and myocardial necrosis leading to a diagnosis of ST elevation myocardial infarction, STEMI, see chap. 295. Clinicians should be aware that unstable ischemic symptoms may also occur predominantly because of increased myocardial oxygen demand, for example, during intense psychological stress or fever, or because of decreased oxygen delivery due to anemia, hypoxia, or hypertension. However, the term acute coronary syndrome, which encompasses unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction, is in general reserved for ischemia precipitated by acute coronary atherothrombosis. In order to guide therapeutic strategies, a standardized system for classification of myocardial infarction has been expanded to discriminate myocardial infarction resulting from acute coronary thrombosis, type 1, from myocardial infarction occurring secondary to other imbalances of myocardial oxygen supply and demand, type 2, see chap. 294. Other contributors to stable and unstable ischemic heart disease, such as endothelial dysfunction, microvascular disease, and vasospasm, may exist alone or in combination with coronary atherosclerosis and may be the dominant cause of myocardial ischemia in some patients. Moreover, non-atherosclerotic processes, including congenital abnormalities of the coronary vessels, myocardial bridging, coronary arteritis, and radiation-induced coronary disease, can lead to coronary obstruction. In addition, conditions associated with extreme myocardial oxygen demand and impaired endocardial blood flow, such as aortic valve disease, chap. 301, hypertrophic cardiomyopathy, or idiopathic dilated cardiomyopathy, chap. 287, can precipitate myocardial ischemia in patients with or without underlying obstructive atherosclerosis. Characteristics of ischemic chest discomfort. The clinical characteristics of angina pectoris, often referred to simply as angina, are highly similar whether the ischemic discomfort is a manifestation of stable ischemic heart disease, unstable angina, or myocardial infarction. The exceptions are differences in the pattern and duration of symptoms associated with these syndromes. Table 19.1. Heberden initially described angina as a sense of strangling and anxiety. Chest discomfort characteristic of myocardial ischemia is typically described as aching, heavy, squeezing, crushing, or constricting. However, in a substantial minority of patients, the quality of discomfort is extremely vague and may be described as a mild tightness, or merely an uncomfortable feeling that sometimes is experienced as numbness or a burning sensation. The site of the discomfort is usually retrosternal, but radiation is common and generally occurs down the ulnar surface of the left arm, the right arm, both arms, neck, jaw, or shoulders may also be involved. These and other characteristics of ischemic chest discomfort pertinent to discrimination from other causes of chest pain are discussed later in this chapter. See approach to the patient. Stable angina usually begins gradually and reaches its maximal intensity over a period of minutes before dissipating within several minutes with rest or with nitroglycerin. The discomfort typically occurs predictably at a characteristic level of exertion or psychological stress. By definition, unstable angina is manifest by self-limited anginal chest discomfort that is exertional but occurs at increased frequency with progressively lower intensity of physical activity or even at rest. Chest discomfort associated with myocardial infarction is typically more severe, is prolonged, usually lasting greater than or equals 30 minutes, and is not relieved by rest. Mechanisms of cardiac pain. The neural pathways involved in ischemic cardiac pain are poorly understood. Ischemic episodes are thought to excite local chemosensitive and mechanoreceptive receptors that, in turn, stimulate release of adenosine, bradykinin, and other substances that activate the sensory ends of sympathetic and vagal afferent fibers. The afferent fibers traverse the nerves that connect to the upper 5 thoracic sympathetic ganglia and upper 5 distal thoracic routes of the spinal cord. From there, impulses are transmitted to the thalamus. Within the spinal cord, cardiac sympathetic afferent impulses may converge with impulses from somatic thoracic structures, and this convergence may be the basis for referred cardiac pain. In addition, cardiac vagal afferent fibers synapse in the nucleus tractus solitarius of the medulla and then descend to the upper cervical spinothalamic tract, and this route may contribute to anginal pain experienced in the neck and jaw. Other cardiopulmonary causes. Pericardial and other myocardial diseases. See also Chap. 288. Inflammation of the pericardium due to infectious or non-infectious causes can be responsible for acute or chronic chest discomfort. The visceral surface and most of the parietal surface of the pericardium are insensitive to pain. Therefore, the pain of pericarditis is thought to arise principally from associated pleural inflammation and is more common with infectious causes of pericarditis, which typically involve the pleura. Because of this pleural association, the discomfort of pericarditis is usually pleuritic pain that is exacerbated by breathing, coughing, or changes in position. Moreover, owing to the overlapping sensory supply of the central diaphragm via the phrenic nerve with somatic sensory fibers originating in the 3rd to 5th cervical segments, the pain of pleural pericarditis is often referred to the shoulder and neck. Involvement of the pleural surface of the lateral diaphragm can lead to pain in the upper abdomen. Acute inflammatory and other non-ischemic myocardial diseases can also produce chest discomfort. The symptoms of Takotsubo, stress-related, cardiomyopathy often start abruptly with chest pain and shortness of breath. This form of cardiomyopathy, in its most recognizable form, is triggered by an emotionally or physically stressful event and may mimic acute myocardial infarction because of its commonly associated ECG abnormalities, including ST segment elevation, and elevated biomarkers of myocardial injury. Observational studies support a predilection for women greater than 50 years of age. The symptoms of acute myocarditis are highly varied. Chest discomfort may either originate with inflammatory injury of the myocardium or be due to severe increases in wall stress related to poor ventricular performance. Diseases of the aorta. See also Chap. 301, Acute aortic dissection, Figure 19.1, is a less common cause of chest discomfort but is important because of the catastrophic natural history of certain subsets of cases when recognized late or left untreated. Acute aortic syndromes encompass a spectrum of acute aortic diseases related to disruption of the media of the aortic wall. Aortic dissection involves a tear in the aortic intima, resulting in separation of the media and creation of a separate false lumen. A penetrating ulcer has been described as ulceration of an aortic atheromatous plaque that extends through the intima and into the aortic media, with the potential to initiate an intramedial dissection or rupture into the adventitia. Intramural hematoma is an aortic wall hematoma with no demonstrable intimal flap, no radiologically apparent intimal tear, and no false lumen. Intramural hematoma can occur due to either rupture of the vasa vasorum or, less commonly, a penetrating ulcer. Each of these subtypes of acute aortic syndrome typically presents with chest discomfort that is often severe, sudden in onset, and sometimes described as tearing in quality. Acute aortic syndromes involving the ascending aorta tend to cause pain in the midline of the anterior chest, whereas descending aortic syndromes most often present with pain in the back. Therefore, dissections that begin in the ascending aorta and extend to the descending aorta tend to cause pain in the front of the chest that extends toward the back, between the shoulder blades. Proximal aortic dissections that involve the ascending aorta, type A in the Stanford nomenclature, are at higher risk for major complications that may influence the clinical presentation, including 1. Compromise of the aortic ostia of the coronary arteries, resulting in myocardial infarction. 2. Disruption of the aortic valve, causing acute aortic insufficiency. And 3. Rupture of the hematoma into the pericardial space, leading to pericardial tamponade. Knowledge of the epidemiology of acute aortic syndromes can be helpful in maintaining awareness of this relatively uncommon group of disorders. Estimated annual incidence, 3 cases per 100,000 population. Non-traumatic aortic dissections are very rare in the absence of hypertension or conditions associated with deterioration of the elastic or muscular components of the aortic media, including pregnancy, bicuspid aortic disease, or inherited connective tissue diseases, such as Marfan and Ehlers-Danlos syndromes. Although aortic aneurysms are most often asymptomatic, thoracic aortic aneurysms can cause chest pain and other symptoms by compressing adjacent structures. This pain tends to be steady, deep, and occasionally severe. Aortitis, whether of non-infectious or infectious etiology, in the absence of aortic dissection is a rare cause of chest or back discomfort. Pulmonary conditions. Pulmonary and pulmonary vascular conditions that cause chest discomfort usually do so in conjunction with dyspnea and often produce symptoms that have a pleuritic nature. Pulmonary embolism. See also Chap. 300, Pulmonary emboli, annual incidence, 1 per 1,000, can produce dyspnea and chest discomfort. That is sudden in onset. Typically pleuritic in pattern. The chest discomfort associated with pulmonary embolism may result from 1. Involvement of the pleural surface of the lung adjacent to a resultant pulmonary infarction, 2. Distension of the pulmonary artery, or 3. Possibly, right ventricular wall stress and or subendocardial ischemia related to acute pulmonary hypertension. The pain associated with small pulmonary emboli is often lateral and pleuritic and is believed to be related to the first of these 3 possible mechanisms. In contrast, massive pulmonary emboli may cause severe substernal pain that may mimic an myocardial infarction and that is plausibly attributed to the second and third of these potential mechanisms. Massive or submassive pulmonary embolism may also be associated with syncope, hypertension, and signs of right heart failure. Other typical characteristics that aid in the recognition of pulmonary embolism are discussed later in this chapter. See Approach to the patient. Pneumothorax. See also Chap. 317. Primary spontaneous pneumothorax is a rare cause of chest discomfort, with an estimated annual incidence in the United States of 7 per 100,000 among men and less than 2 per 100,000 among women. Risk factors include male sex, smoking, family history, and Marfan syndrome. The symptoms are usually sudden in onset, and dyspnea may be mild, thus, presentation to medical attention is sometimes delayed. Secondary spontaneous pneumothorax may occur in patients with underlying lung disorders, such as chronic obstructive pulmonary disease, asthma, or cystic fibrosis, and usually produces symptoms that are more severe. Tension pneumothorax is a medical emergency caused by trapped intrathoracic air that precipitates hemodynamic collapse. Other pulmonary parenchymal, pleural, or vascular disease. See also CHAPS 304, 305, and 316. Most pulmonary diseases that produce chest pain, including pneumonia and malignancy, do so because of involvement of the pleura or surrounding structures. Pleurisy is typically described as a knife-like pain that is worsened by inspiration or coughing. In contrast, chronic pulmonary hypertension can manifest as chest pain that may be very similar to angina in its characteristics, suggesting right ventricular myocardial ischemia in some cases. Reactive airways diseases similarly can cause chest tightness associated with breathlessness rather than pleurisy. Non-cardiopulmonary causes. Gastrointestinal conditions. See also CHAP 344. Gastrointestinal disorders are the most common cause of non-traumatic chest discomfort and often produce symptoms that are difficult to discern from more serious causes of chest pain, including myocardial ischemia. Esophageal disorders, in particular, may simulate angina in the character and location of the pain. Gastroesophageal reflux and disorders of esophageal motility are common and should be considered in the differential diagnosis of chest pain, Figure 19.1 and Table 19.1. Acid reflux often causes a burning discomfort. The pain of esophageal spasm, in contrast, is commonly an intense, squeezing discomfort that is retrosternal in location and, like angina, may be relieved by nitroglycerin or dihydropyridine calcium channel antagonists. Chest pain can also result from injury to the esophagus, such as a Mallory Weiss tear or even an esophageal rupture, Bauer-Haave syndrome, caused by severe vomiting. Peptic ulcer disease is most commonly epigastric in location but can radiate into the chest, Table 19.1. Hepatobiliary disorders, including cholecystitis and biliary colic, may mimic acute cardiopulmonary diseases. Although the pain arising from these disorders usually localizes to the right upper quadrant of the abdomen, it is variable and may be felt in the epigastrium and radiate to the back and lower chest. This discomfort is sometimes referred to the scapula or may in rare cases be felt in the shoulder, suggesting diaphragmatic irritation. The pain is steady, usually lasts several hours, and subsides spontaneously, without symptoms between attacks. Pain resulting from pancreatitis is typically aching epigastric pain that radiates to the back. Musculoskeletal and other causes. See also CHAP 393. Chest discomfort can be produced by any musculoskeletal disorder involving the chest's wall or the nerves of the chest wall, neck, or upper limbs. Costochondritis causing tenderness of the costochondral junctions, Tietze's syndrome, is relatively common. Cervical radiculitis may manifest as a prolonged or constant aching discomfort in the upper chest and limbs. The pain may be exacerbated by motion of the neck. Occasionally, chest pain can be caused by compression of the brachial plexus by the cervical ribs, and tendinitis or bursitis involving the left shoulder may mimic the radiation of angina. Pain in a dermatomal distribution can also be caused by cramping of intercostal muscles or by herpes zoster, CHAP 217. Emotional and psychiatric conditions. As many as 10% of patients who present to emergency departments with acute chest discomfort have a panic disorder or related condition, Table 19.1. The symptoms may include chest tightness or aching that is associated with a sense of anxiety and difficulty breathing. The symptoms may be prolonged or fleeting. Approach to the patient, chest discomfort. Given the broad set of potential causes and the heterogeneous risk of serious complications in patients who present with acute non-traumatic chest discomfort, the priorities of the initial clinical encounter include assessment of 1. The patient's clinical stability and 2. The probability that the patient has an underlying cause of the discomfort that may be life-threatening. The higher-risk conditions of principal concern are acute cardiopulmonary processes, including acute coronary syndrome, acute aortic syndrome, pulmonary embolism, tension pneumothorax, and pericarditis with tamponade. Among non-cardiopulmonary causes of chest pain, esophageal rupture likely holds the greatest urgency for diagnosis. Patients with these conditions may deteriorate rapidly despite initially appearing well. The remaining population with non-cardiopulmonary conditions has a more favorable prognosis during completion of the diagnostic workup. A rapid targeted assessment for a serious cardiopulmonary cause is of particular relevance for patients with acute ongoing pain who have presented for emergency evaluation. Among patients presenting in the outpatient setting with chronic pain or pain that has resolved, a general diagnostic assessment is reasonably undertaken. See outpatient evaluation of chest discomfort, below. A series of questions that can be used to structure the clinical evaluation of patients with chest discomfort is shown in Table 19.2. History. The evaluation of non-traumatic chest discomfort relies heavily on the clinical history and physical examination to direct subsequent diagnostic testing. The evaluating clinician should assess the quality, location, including radiation, and pattern, including onset and duration, of the pain as well as any provoking or alleviating factors. The presence of associated symptoms may also be useful in establishing a diagnosis. Quality of pain. The quality of chest discomfort alone is never sufficient to establish a diagnosis. However, the characteristics of the pain are pivotal in formulating an initial clinical impression and assessing the likelihood of a serious cardiopulmonary process. Table 19.1, including X in particular, Figure 19.2. Pressure or tightness is consistent with a typical presentation of myocardial ischemic pain. Nevertheless, the clinician must remember that some patients with ischemic chest symptoms deny any pain but rather complain of dyspnea or a vague sense of anxiety. The severity of the discomfort has poor diagnostic accuracy. It is often helpful to ask about the similarity of the discomfort to previous definite ischemic symptoms. It is unusual for angina to be sharp, as in knife-like, stabbing, or pleuritic. However, patients sometimes use the word sharp to convey the intensity of discomfort rather than the quality. Pleuritic discomfort is suggestive of a process involving the pleura, including pericarditis, pulmonary embolism, or pulmonary parenchymal processes. Less frequently, the pain of pericarditis or massive pulmonary embolism is a steady severe pressure or aching that can be difficult to discriminate from myocardial ischemia. Tearing or ripping pain is often described by patients with acute aortic dissection. However, acute aortic emergencies also present commonly with severe, knife-like pain. A burning quality can suggest acid reflux or peptic ulcer disease but may also occur with myocardial ischemia. Esophageal pain, particularly with spasm, can be a severe squeezing discomfort identical to angina. Location of discomfort. A substernal location with radiation to the neck, jaw, shoulder, or arms is typical of myocardial ischemic discomfort. Some patients present with aching in sites of radiated pain as their only symptoms of ischemia. However, pain that is highly localized, for example, that which can be demarcated by the tip of one finger, is highly unusual for angina. A retrosternal location should prompt consideration of esophageal pain. However, other gastrointestinal conditions usually present with pain that is most intense in the abdomen or epigastrium, with possible radiation into the chest. Angina may also occur in an epigastric location. However, pain that occurs solely above the mandible or below the epigastrium is rarely angina. Severe pain radiating to the back, particularly between the shoulder blades, should prompt consideration of an acute aortic syndrome. Radiation to the trapezius ridge is characteristic of pericardial pain and does not usually occur with angina. Pattern. Myocardial ischemic discomfort usually builds over minutes and is exacerbated by activity and mitigated by rest. In contrast, Pain that reaches its peak intensity immediately is more suggestive of aortic dissection, pulmonary embolism, or spontaneous pneumothorax. Pain that is fleeting, lasting only a few seconds, is rarely ischemic in origin. Similarly, pain that is constant in intensity for a prolonged period, many hours to days, is unlikely to represent myocardial ischemia if it occurs in the absence of other clinical consequences, such as abnormalities of the ECG, elevation of cardiac biomarkers, or clinical sequelae, for example, heart failure or hypertension. Both myocardial ischemia and acid reflux may have their onset in the morning, the latter because of the absence of food to absorb gastric acid. Provoking and alleviating factors. Patients with myocardial ischemic pain usually prefer to rest, sit, or stop walking. However, clinicians should be aware of the phenomenon of warm-up angina, in which some patients experience relief of angina as they continue at the same or even a greater level of exertion without symptoms. Chap. 293. Alterations in the intensity of pain with changes in position or movement of the upper extremities and neck are less likely with myocardial ischemia and suggest a musculoskeletal etiology. The pain of pericarditis, however, often is worse in the supine position and relieved by sitting upright and leaning forward. Gastroesophageal reflux may be exacerbated by alcohol, some foods, or by a reclined position. Relief can occur with sitting. Exacerbation by eating suggests a gastrointestinal etiology such as peptic ulcer disease, cholecystitis, or pancreatitis. Peptic ulcer disease tends to become symptomatic 60 to 90 minutes after meals. However, in the setting of severe coronary atherosclerosis, redistribution of blood flow to the splenic vasculature after eating can trigger postprandial angina. The discomfort of acid reflux and peptic ulcer disease is usually diminished promptly by acid-reducing therapies. In contrast with its impact in some patients with angina, physical exertion is very unlikely to alter symptoms from gastrointestinal causes of chest pain. Relief of chest discomfort within minutes after administration of nitroglycerin is suggestive of but not sufficiently sensitive or specific for a definitive diagnosis of myocardial ischemia. Esophageal spasm may also be relieved promptly with nitroglycerin. A delay of greater than 10 minutes before relief is obtained after nitroglycerin suggests that the symptoms either are not caused by ischemia or are caused by severe ischemia, such as during acute myocardial infarction. Associated symptoms. Symptoms that accompany myocardial ischemia may include diaphoresis, dyspnea, nausea, fatigue, faintness, and irritations. In addition, these symptoms may exist in isolation as anginal equivalents, that is, symptoms of myocardial ischemia other than typical angina, particularly in women and the elderly. Dyspnea may occur with multiple conditions considered in the differential diagnosis of chest pain and thus is not discriminative, but the presence of dyspnea is important because it suggests a cardiopulmonary etiology. Sudden onset of significant respiratory distress should lead to consideration of pulmonary embolism and spontaneous pneumothorax. Hemoptysis may occur with pulmonary embolism, or as blood-tinged frothy sputum in severe heart failure, but usually points toward a pulmonary parenchymal etiology of chest symptoms. Presentation with syncope or pre-syncope should prompt consideration of hemodynamically significant pulmonary embolism or aortic dissection as well as ischemic arrhythmias. Although nausea and vomiting suggest a gastrointestinal disorder, these symptoms may occur in the setting of myocardial infarction, more commonly inferior myocardial infarction, presumably because of activation of the vagal reflex or stimulation of left ventricular receptors as part of the Biselt-Jarvis reflex. Past medical history. The past medical history is useful in assessing the patient for risk factors for coronary atherosclerosis, Chap. 291E, and venous thromboembolism, Chap. 300. As well as for conditions that may predispose the patient to specific disorders. For example, A history of connective tissue diseases such as Marfan syndrome should heighten the clinician's suspicion of an acute aortic syndrome or spontaneous pneumothorax. A careful history may elicit clues about depression or prior panic attacks. Physical examination. In addition to providing an initial assessment of the patient's clinical stability, the physical examination of patients with chest discomfort can provide direct evidence of specific etiologies of chest pain, for example, unilateral absence of lung sounds, and can identify potential precipitants of acute cardiopulmonary causes of chest pain, for example, uncontrolled hypertension, relevant comorbid conditions, for example, obstructive pulmonary disease, and complications of the presenting syndrome, for example, heart failure. However, because the findings on physical examination may be normal in patients with unstable ischemic heart disease, an unremarkable physical exam is not definitively reassuring. General. The patient's general appearance is helpful in establishing an initial impression of the severity of illness. Patients with acute myocardial infarction or other acute cardiopulmonary disorders often appear anxious, uncomfortable, pale, cyanotic, or diaphoretic. Patients who are massaging or clutching their chests may describe their pain with a clenched fist held against the sternum, Levine's sign. Occasionally, body habitus is helpful, for example, in patients with Marfan syndrome or the prototypical young, tall, thin man with spontaneous pneumothorax. Vital signs. Significant tachycardia and hypertension are indicative of important hemodynamic consequences of the underlying cause of chest discomfort and should prompt a rapid survey for the most severe conditions, such as acute myocardial infarction with cardiogenic shock, massive pulmonary embolism, pericarditis with tamponade, or tension pneumothorax. Acute aortic emergencies usually present with severe hypertension but may be associated with profound hypertension when there is coronary arterial compromise or dissection into the pericardium. Sinus tachycardia is an important manifestation of submassive pulmonary embolism. Tachypnea and hypoxemia point toward a pulmonary cause. The presence of low-grade fever is non-specific because it may occur with myocardial infarction and with thromboembolism in addition to infection. Pulmonary examination of the lungs may localize a primary pulmonary cause of chest discomfort, as in cases of pneumonia, asthma, or pneumothorax. Left ventricular dysfunction from severe ischemia, infarction as well as acute valvular complications of myocardial infarction or aortic dissection can lead to pulmonary edema, which is an indicator of high risk. Cardiac. The jugular venous pulse is often normal in patients with acute myocardial ischemia but may reveal characteristic patterns with pericardial tamponade or acute right ventricular dysfunction, CHAPS. 267 and 288. Cardiac auscultation may reveal a third or, more commonly, a fourth heart sound, reflecting myocardial systolic or diastolic dysfunction. Murmurs of mitral regurgitation or a harsh murmur of a ventricular septal defect may indicate mechanical complications of ST elevation myocardial infarction. A murmur of aortic insufficiency may be a complication of proximal aortic dissection. Other murmurs may reveal underlying cardiac disorders contributory to ischemia, for example, aortic stenosis or hypertrophic cardiomyopathy. Pericardial friction rubs reflect pericardial inflammation. Abdominal. Localizing tenderness on the abdominal exam is useful in identifying a gastrointestinal cause of the presenting syndrome. Abdominal findings are infrequent with purely acute cardiopulmonary problems, except in the case of underlying chronic cardiopulmonary disease or severe right ventricular dysfunction leading to hepatic congestion. Vascular. Pulse deficits may reflect underlying chronic atherosclerosis, which increases the likelihood of coronary artery disease. However, evidence of acute limb ischemia with loss of the pulse and pella, particularly in the upper extremities, can indicate catastrophic consequences of aortic dissection. Unilateral lower extremity swelling should raise suspicion about venous thromboembolism. Musculoskeletal. Pain arising from the costochondral and chondrosternal articulations may be associated with localized swelling, redness, or marked localized tenderness. Pain on palpation of these joints is usually well localized and is a useful clinical sign, though deep palpation may elicit pain in the absence of costochondritis. Although palpation of the chest wall often elicits pain in patients with various musculoskeletal conditions, it should be appreciated that chest wall tenderness does not exclude myocardial ischemia. Sensory deficits in the upper extremities may be indicative of cervical disc disease. Electrocardiography. Electrocardiography is crucial in the evaluation of non-traumatic chest discomfort. The ECG is pivotal for identifying patients with ongoing ischemia as the principal reason for their presentation, as well as secondary cardiac complications of other disorders. Professional society guidelines recommend that an ECG be obtained within 10 minutes of presentation, with the primary goal of identifying patients with ST segment elevation diagnostic of myocardial infarction who are candidates for immediate interventions to restore flow in the occluded coronary artery. ST segment depression and symmetric T-wave inversions at least 0.2 mV in depth are useful for detecting myocardial ischemia in the absence of ST elevation myocardial infarction and are also indicative of higher risk of death or recurrent ischemia. Serial performance of ECGs, every 30 to 60 minutes, is recommended in the emergency department evaluation of suspected acute coronary syndrome. In addition, an ECG with right-sided lead placement should be considered in patients with clinically suspected ischemia and a non-diagnostic standard 12-lead ECG. Despite the value of the resting ECG, its sensitivity for ischemia is poor, as low as 20% in some studies. Abnormalities of the ST segment and T-wave may occur in a variety of conditions, including pulmonary embolism, ventricular hypertrophy, acute and chronic pericarditis, myocarditis, electrolyte imbalance, and metabolic disorders. Notably, hyperventilation associated with panic disorder can also lead to nonspecific ST and T-wave abnormalities. Pulmonary embolism is most often associated with sinus tachycardia but can also lead to rightward shift of the ECG axis, manifesting as an S-wave in lead 1, with a Q-wave and T-wave in lead 3, CHAPS 268 and 300. In patients with ST segment elevation, the presence of diffuse lead involvement not corresponding to a specific coronary anatomic distribution and PR segment depression can aid in distinguishing pericarditis from acute myocardial infarction. Chest radiography. See CHAP 380. Plain radiography of the chest is performed routinely when patients present with acute chest discomfort and selectively when individuals who are being evaluated as outpatients have subacute or chronic pain. The chest radiograph is most useful for identifying pulmonary processes, such as pneumonia or pneumothorax. Findings are often unremarkable in patients with acute coronary syndrome, but pulmonary edema may be evident. Other specific findings include widening of the mediastinum in some patients with aortic dissection, Hampton's hump or Westermarck's sign in patients with pulmonary embolism, CHAPS 300 and 380, or pericardial calcification in chronic pericarditis. Cardiac biomarkers. Laboratory testing in patients with acute chest pain is focused on the detection of myocardial injury. Such injury can be detected by the presence of circulating proteins released from damaged myocardial cells. Owing to the time necessary for this release, initial biomarkers of injury may be in the normal range, even in patients with ST elevation myocardial infarction. Because of superior cardiac tissue specificity compared with creatine kinase MB, cardiac troponin is the preferred biomarker for the diagnosis of myocardial infarction and should be measured in all patients with suspected acute coronary syndrome at presentation and repeated in 3 to 6 hours. Testing after 6 hours is required only when there is uncertainty regarding the onset of pain or when stuttering symptoms have occurred. it is not necessary or advisable to measure troponin in patients without suspicion of acute coronary syndrome unless this test is being used specifically for risk stratification, for example, in pulmonary embolism or heart failure. The development of cardiac troponin assays with progressively greater analytical sensitivity has facilitated detection of substantially lower blood concentrations of troponin than was previously possible. This evolution permits earlier detection of myocardial injury, enhances the overall accuracy of a diagnosis of myocardial infarction, and improves risk stratification in suspected acute coronary syndrome. The great negative predictive value of a negative troponin result with current generation assays is an advantage in the evaluation of chest pain in the emergency department. Rapid rule-out protocols that use serial testing and changes in troponin concentration over as short a period as 1 to 2 hours appear promising and remain under investigation. However, with these advantages has come a trade-off. Myocardial injury is detected in a larger proportion of patients who have non-acute coronary syndrome cardiopulmonary conditions than with previous, less sensitive assays. This evolution in testing for myocardial necrosis has rendered other aspects of the clinical evaluation critical to the practitioner's determination of the probability that the symptoms represent acute coronary syndrome. In addition, observation of a change in cardiac troponin concentration between serial samples is useful in discriminating acute causes of myocardial injury from chronic elevation due to underlying structural heart disease. End-stage renal disease, or interfering antibodies. The diagnosis of myocardial infarction is reserved for acute myocardial injury that is marked by a rising and/or falling pattern, with at least one value exceeding the 99th percentile reference limit, and that is caused by ischemia. Other non-ischemic insults, such as myocarditis, may result in myocardial injury but should not be labeled myocardial infarction. Other laboratory assessments may include the D-dimer test to aid in exclusion of pulmonary embolism, CHAP 300. Measurement of a B-type natriuretic peptide is useful when considered in conjunction with the clinical history and exam for the diagnosis of heart failure. B-type natriuretic peptides also provide prognostic information regarding patients with acute coronary syndrome and those with pulmonary embolism. Other putative biomarkers of acute myocardial ischemia or acute coronary syndrome, such as mieloperoxidase, have not been adopted in routine use. Integrative decision aids. Multiple clinical algorithms have been developed to aid in decision-making during the evaluation and disposition of patients with acute non-traumatic chest pain. Such decision aids have been derived on the basis of their capacity to estimate either of two closely related but not identical probabilities. 1. The probability of a final diagnosis of acute coronary syndrome and 2. The probability of major cardiac events during short-term follow-up. Such decision aids are used most commonly to identify patients with a low clinical probability of acute coronary syndrome who are candidates either for early provocative testing for ischemia or for discharge from the emergency department. Goldman and Lee developed one of the first such decision aids, using only the ECG and risk indicators, hypertension, pulmonary rales, and known ischemic heart disease, to categorize patients into 4 risk categories ranging from a less than 1% to a greater than 16% probability of a major cardiovascular complication. The acute cardiac ischemia time and sensitive predictive instrument, ACTIP, combines age, sex, chest pain presence, and ST segment abnormalities to define a probability of acute coronary syndrome. More recently developed decision aids are shown in Figure 19.3. Elements common to each of these tools are 1. Symptoms typical for acute coronary syndrome, 2. Older age, 3. Risk factors for all known atherosclerosis, 4. Ischemic ECG abnormalities, and 5. Elevated cardiac troponin levels. Although, because of very low specificity, the overall diagnostic performance of such decision aids is poor, area under the receiver operating curve, 0.55 to 0.65. They can help identify patients with a very low probability of acute coronary syndrome, for example, less than 1%. Nevertheless, no such decision aid, or single clinical factor, is sufficiently sensitive and well validated to use as a sole tool for clinical decision-making. Clinicians should differentiate between the algorithms discussed above and risk scores derived for stratification of prognosis, for example, the thrombolysis in myocardial infarction, TIMI, and GRACE risk scores, CHAP 295, in patients who already have an established diagnosis of acute coronary syndrome. The latter risk scores were not designed to be used for diagnostic assessment. Provocative testing for ischemia. Exercise electrocardiography, stress testing, is commonly employed for completion of risk stratification of patients who have undergone an initial evaluation that has not revealed a specific cause of chest discomfort and has identified them as being at low or selectively intermediate risk of acute coronary syndrome. Early exercise testing is safe in patients without high-risk findings after 8 to 12 hours of observation and can assist in refining their prognostic assessment. For example, of low-risk patients who underwent exercise testing in the first 48 hours after presentation, those without evidence of ischemia had a 2% rate of cardiac events through 6 months, whereas the rate was 15% among patients with either clear evidence of ischemia or an equivocal result. Patients who are unable to exercise may undergo pharmacological stress testing with either nuclear perfusion imaging or echocardiography. Notably, some experts have deemed the routine use of stress testing for low-risk patients unsupported by direct clinical evidence and a potentially unnecessary source of cost. Professional society guidelines identify ongoing chest pain as a contraindication to stress testing. In selected patients with persistent pain and non-diagnostic ECG and biomarker data, resting myocardial perfusion images can be obtained. The absence of any perfusion abnormality substantially reduces the likelihood of coronary artery disease. In some centers, early myocardial perfusion imaging is performed as part of a routine strategy for evaluating patients at low or intermediate risk of acute coronary syndrome in parallel with other testing. Management of patients with normal perfusion images can be expedited with earlier discharge and outpatient stress testing, if indicated. Those with abnormal rest perfusion imaging, which cannot discriminate between old or new myocardial defects, must undergo additional in-hospital evaluation. Other non-invasive studies. Other non-invasive imaging studies of the chest can be used selectively to provide additional diagnostic and prognostic information on patients with chest discomfort. Echocardiography. Echocardiography is not necessarily routine in patients with chest discomfort. However, in patients with an uncertain diagnosis, particularly those with non-diagnostic ST elevation, ongoing symptoms, or hemodynamic instability, detection of abnormal regional wall motion provides evidence of possible ischemic dysfunction. Echocardiography is diagnostic in patients with mechanical complications of myocardial infarction or in patients with pericardial tamponade. Transthoracic echocardiography is poorly sensitive for aortic dissection, although an intimal flap may sometimes be detected in the ascending aorta. CT angiography. See Chap 270E. CT angiography is emerging as a modality for the evaluation of patients with acute chest discomfort. Coronary CT angiography is a sensitive technique for detection of obstructive coronary disease, particularly in the proximal third of the major epicardial coronary arteries. CT appears to enhance the speed to disposition of patients with a low intermediate probability for acute coronary syndrome, its major strength being the negative predictive value of a finding of no significant disease. In addition, contrast-enhanced CT can detect focal areas of myocardial injury in the acute setting as decreased areas of enhancement. At the same time, CT angiography can exclude aortic dissection, pericardial effusion, and pulmonary embolism. balancing factors in the consideration of the emerging role of coronary CT angiography in low-risk patients are radiation exposure and additional testing prompted by non-diagnostic abnormal results. MRI, see Chap. 270E. Cardiac magnetic resonance, CMR, imaging is an evolving, versatile technique for structural and functional evaluation of the heart and the vasculature of the chest. Cardiac magnetic resonance accurately measures ventricular dimensions and function and can be performed as a modality for pharmacologic stress perfusion imaging. Gadolinium-enhanced cardiac magnetic resonance can provide early detection of myocardial infarction, defining areas of myocardial necrosis accurately, and can delineate patterns of myocardial disease that are often useful in discriminating ischemic from non-ischemic myocardial injury. Although usually not practical for the urgent evaluation of acute chest discomfort, cardiac magnetic resonance can be a useful modality for cardiac structural evaluation of patients with elevated cardiac troponin levels in the absence of definite coronary artery disease. Cardiac magnetic resonance coronary angiography is in its early stages. MRI also permits highly accurate assessment for aortic dissection but is infrequently used as the first test because CT and transesophageal echocardiography are usually more practical. Critical pathways for acute chest discomfort. Because of the challenges inherent in reliably identifying the small proportion of patients with serious causes of acute chest discomfort while not exposing the larger number of low-risk patients to unnecessary testing and extended emergency department or hospital evaluations, many medical centers have adopted critical pathways to expedite the assessment and management of patients with non-traumatic chest pain, often in dedicated chest pain units. Such pathways are generally aimed at 1. Rapid identification, triage, and treatment of high-risk cardiopulmonary conditions, for example, ST elevation myocardial infarction. 2. Accurate identification of low-risk patients who can be safely observed in units with less intensive monitoring, undergo early exercise testing, or be discharged home. And 3. Through more efficient and systematic accelerated diagnostic protocols, safe reduction in costs associated with overuse of testing and unnecessary hospitalizations. In some studies, provision of protocol-driven care in chest pain units has decreased costs and overall duration of hospital evaluation with no detectable excess of adverse clinical outcomes. Outpatient evaluation of chest discomfort. Chest pain is common in outpatient practice, with a lifetime prevalence of 20 to 40% in the general population. More than 25% of patients with myocardial infarction have had a related visit with a primary care physician in the previous month. The diagnostic principles are the same as in the emergency department. However, the pretest probability of an acute cardiopulmonary cause is significantly lower. Therefore, testing paradigms are less intense, with an emphasis on the history, physical examination, and ECG. Moreover, decision aids developed for settings with a high prevalence of significant cardiopulmonary disease have lower positive predictive value when applied in the practitioner's office. However, in general, if the level of clinical suspicion of acute coronary syndrome is sufficiently high to consider troponin testing, the patient should be referred to the emergency department for evaluation.